Hello, my name is Dr. Zachary Coburn, and together with Dr. Brian Frody, we will be discussing ED volume during the COVID-19 pandemic. We have no financial conflicts of interest to disclose. Research on ED volume during previous epidemics, including the 2003 SARS and 2009 H1N1 influenza outbreaks, noted variable and short-lived effects on ED volume. COVID-19, however, differs from these previous outbreaks in both the prolonged nature of the pandemic as well as how widespread its effects were. Additionally, it differs in that its onset in the Northern Hemisphere coincided with the tapering of the cold and flu season, during which many EDs experienced seasonal volume reductions. Several studies have confirmed an overall reduction in ED volume during COVID-19 in the United States, especially amongst the pediatric population. The duration of this effect, especially later into the summer, and its impact on patient acuity are less well documented. The goals of our study were to determine whether the decline in ED patient volume was outside the expected seasonal drop in visits, and if that drop was sustained. Additionally, we aimed to determine whether the number of critically ill patients in 2020 was higher than previous years and represented a higher proportion of overall ED visits. We performed a single institution retrospective review of ED visits, including analysis of patient demographics, level of acuity, and other operational variables noted below from December of 2015 through November of 2020. Our ED is a large academic medical center in upstate New York with an annual census of approximately 88,000 patients per year, and with dedicated adult and pediatric EDs. Daily ED visits were summarized over 13 annual 4-week billing cycles, and graphs of key outcome variables were then created.
Key patient demographics over the study period are outlined in Table 1. As you can see, there was a steady increase in emergency department volumes and the percentage of transfers before the pandemic. Most notably, there was a marked increase in pediatric patients coinciding with the opening of our dedicated pediatric ED in 2018. This figure demonstrates a pattern of seasonal variability in emergency department volume, with peaks occurring in the winter and summer months. Combined adult and pediatric volumes peaked between January and February of 2020, with 7,448 total encounters, compared with an average of 6,504 visits during the same cycle between 2016 and 2019. Much of the spike in February of 2020 can be accounted for by an increase in pediatric volume and pediatric transfers. There's a near 50% drop in the total emergency department volume beginning late February through March to 3,777 patients. Subsequently, adult volume is noted to have recovered to near prior levels, but pediatric volume has stayed low, approximately 50% of the average volume before the COVID-19 pandemic. This slide shows EM coding and the percentage of patients with billed critical care time. Note in the March and April cycles, the marked increase in level 1 and level 2 billing that peaked at 23.9%. This corresponds to a period when we were operating an outdoor screening tent for patients with respiratory symptoms that used paper charting. The tent closed in late April, and as you can see, EM billing returned to the previous baselines following this closure. Critical care billing increased dramatically, reaching a peak of 7.5% in April and May of 2020, compared to a pre-COVID-19 mean of 4.8%, which then dropped but remains between 2 to 3 standard deviations higher than the prior baseline. This final figure shows incoming transfers in psychiatric patients. The number of patients who were admitted or transferred to an inpatient psychiatric unit decreased to a low of 87 during April into May of 2020, compared to a pre-2020 mean of 140 patients per billing cycle. However, in the context of our overall lower emergency department volume, this actually represented a proportional increase of 2.3% of total visits from a pre-2020 mean of 1.7%. Similarly, while the total number of transfers to our hospital declined, the proportion of transfers increased, representing 15.9% of ED patients during the spring of 2020, compared to a pre-2020 mean of 13%. In summary, our study confirmed that the drop seen in the spring of 2020 of emergency department volume was greater than what we would have expected from seasonal variation, and that the decline was sustained, most notably among pediatric emergency department patients. And acuity, as measured by critical care billing, the proportion of inpatient psychiatric admissions and the proportion of transferred patients into our institution, reached an all-time high, and while it has fallen, it remains above the previous baseline. Below are the cited references for our study. Thank you.
Hi, my name is Carly Easton. I'm an associate professor at the University of Arkansas for Medical Sciences in Little Rock, Arkansas. And I'm here to present our abstract, The Physician in Triage Model Improves the Overall Proportion of Patients Treated. I have no financial disclosures. This is important because left without being seen is a national benchmark for CMS and is often tied to hospital reimbursement. High left without being seen rates lead to high morbidity because patients are not fully evaluated, a lot of loss of revenue, and frustration for clinicians. When we saw at our level 1 trauma center that our left without being seen rates were approaching 6, sometimes 8%, we formed a group who decided we would start an attending physician in triage, or a PIT. This was initially an quality improvement initiative. We implemented it first in September 2018 for 6 hours, Monday through Friday, 9 a.m. to 3 p.m. And then in 2019, we expanded this to 12 hours a day, Monday through Friday, 9 a.m. to 9 p.m. The flow is that each patient presents to triage. When they're triaged by the nurse, the attending physician is present, and they're screened together. The attending writes a brief note and then orders relevant testing. If possible, the patient goes to the next station, which is EKG and lab draw, and then they go back to the waiting room if a room is not available. We wanted to analyze the effects of the PIT model, so we retrospectively analyzed our pre and post PIT metrics. We have 3 groups: a pre-PIT group, which is April to September 2018, a 6-hour PIT group, which is September 2018 to June 2019, and a 12-hour PIT group from July 2019 to the end of February 2020. And we stopped at the end of February because the pandemic started and dramatically affected our ED volumes. So we wanted to minimize confounding due to the change in the volumes. Our primary outcome was the left without treatment, and this is the sum of the left without being seen rate and the elopement rate. And this represents the number of patients who leave without completing their visit. And these are really the patients that we care about, because we don't want to just check a box. We wanted to make sure that patients were actually being treated. Our secondary outcomes are left without being seen and elopement as separate metrics, and also door to doc. We analyzed 115,414 visits between April 2018 and the end of February 2020. They had similar demographics and triage emergency severity index levels. The total number is in the top row here. The left without treatment started at 7.08%, and after the 12-hour PIT decreased to 5.9%. Our left without being seen, as expected, also decreased from 6.5% to 2.63% after the 12-hour PIT. And elopement increased, unfortunately, from 0.5% to 3.3%. And we did expect some elopement because patients, after they're seen, sometimes have to go back to the waiting room. This is a graphical representation of the same numbers. The blue line represents the left without treatment, or the patients who left without completing their visit. The red line represents left without being seen, and the green line represents the elopement. So while the elopement rate did increase, which we expected to some degree because patients will still have to go back out to the waiting room, because of the very dramatic decrease in left without being seen, we found a significant difference, or a significant reduction in the left without treatment by a negative 3.5%. So 3.5% more patients were able to be fully evaluated during their visit. Our door to doc time decreased from 55 minutes to 42 minutes, And so we felt more patients were fully evaluated. We did not find much of a difference in the 6-hour PIT, however, but all of these differences were found after we implemented the 12-hour PIT. So for our institution, PIT has been very effective, and despite the increase in elopement, more patients were fully treated and completed their visit. Our next step will be to look at outcomes of these elopements, and we're already doing this and finding that a significant proportion, up to 8%, are actually being admitted within 72 hours. And the majority of these are because of abnormalities found on those tests ordered by the physician in triage. We're also looking at other time-based metrics such as ED length of stay and door to disposition time. We will look at financial impact and changes in revenue, and then also patient satisfaction. I want to thank our team of docs who helped implement this quality improvement initiative, and also nursing staff and our data analysts. Do you have any questions?
Good afternoon. My name is Deb Sengupta, and I am a fourth-year emergency medicine resident at Mount Sinai Hospital. Today, I'll be discussing the characteristics of emergency department utilization during the COVID-19 pandemic. I have no financial conflicts of interest. So this project is born out of an interest in gaining a better understanding in how patient arrivals changed at Mount Sinai Hospital, particularly during the first wave of the pandemic. We had diagnosed our first patient just a week and a half before the WHO declared COVID an international pandemic. And like many other hospitals at the time, Mount Sinai was working to make space for an anticipated demand in ICU beds. We expected to see a high volume of sick COVID patients and wanted to be ready. Sinai had repurposed 94 inpatient beds into 240 ICU beds and also created new patient care spaces such as in the lobby, the Central Park tent, et cetera. And in the ED, we expanded our 5-bed space into a 13-bed critical care bay. We also created a 14-bed step-down unit to meet this demand. And yet early reports from the CDC show a sharp decrease in overall ED volumes during this period. We saw more worrisome was the decline in patients coming in for high acuity illnesses such as heart attacks and strokes and DKA. And so we were interested in understanding the composition of those who did visit the ED, specifically looking at the distribution of respiratory illness and patient severity. Who actually came in and how sick were they? Did we see the same decline in high acuity non-respiratory illnesses that was seen in the CDC data? And even the respiratory patients, how sick were they compared to what we typically see? We did a retrospective cohort study of all adult arrivals at Mount Sinai seen between March 1st and May 31st, and then we had used 2019 data as a comparison group. We pulled some demographic data and ended up with 37,000 visits. Each visit was coded as either respiratory if it included some key terms, such as cough, hypoxia, and everyone else was coded as non-respiratory. We determined acuity by ESI level, which was assigned at triage and has previously been shown to be a reliable indicator of severity. And so ESI 1 and 2 were high acuity. And then we used 2 proportion t-tests to do a majority of our analyses. Consistent with the CDC data, we also saw a sharp decline in ED volumes. After we had this peak in early March, we see a decline. And in April, there's a 41% decline in volumes compared to 2019. Whereas in 2020, in May, you see a 45% decline. There was no variation in decline, disproportional decline by race, age, gender, or insurance status. This is a 100% stacked bar chart showing 2019 volumes against 2020 volumes. The volumes, keep in mind, in 2020 are lower, but this is built to show the proportions. So the gross number showed inside the bar of respiratory-related visits nearly doubled from 2019 to 2020. But while respiratory patients made up 12% of patients in 2019, they made up 32% of patients in 2020. The acuity, interestingly, did not change. 27% of our patients were deemed high acuity in 2019, and it stayed 27%, and it stayed 27% in 2020. So the decrease in high acuity patients, volume-wise, was proportional to the decrease in lower acuity patients. We can get a little more information about this when we look at the change in acuity over time. So there's a lot going on this slide, but we're going to go through it piece by piece. And this green area is the non-respiratory cases, with darker green being high acuity non-respiratory. So what we see is that there's a relatively stable amount of each of these patient groups in 2019 on the left, but we did see a decrease in non-respiratory diagnoses. So from 2019 to 2020. Interestingly, acuity remained about the same. We had 25% high acuity patients in 2019 amongst non-respiratory patients. And in 2020, amongst non-respiratory patients, that proportion of high acuity patients stayed at 25. Admissions also stayed 27%. This tells us that there was variation in volume, but the variation in acuity and admission did not change significantly. Looking at the respiratory data, we see that there's, again, in 2019, there's a relatively stable volume and acuity over that period. But the 2020 respiratory patients did behave very differently. If you look at the dark blue area, you can see that the high acuity patients did increase, and then they peaked in early April. The lower acuity patients had a peak just before that. The total number of respiratory patients, as we know, did increase, but we actually ended up with a lower proportion of high acuity patients. So the high acuity patients dropped from 39% to 33%. We did end up with a higher proportion of admissions, suggesting that this was a sick population. Our data corroborates what was seen nationally with the CDC data, in that we also saw a decrease in high acuity non-respiratory illnesses. We saw a proportional decline in low acuity non-respiratory illnesses. And the fact that we saw proportional declines across acuity for non-respiratory illnesses, this is suggestive of patients' ability or difficulty triaging themselves based on their severity. We saw an expected increase in respiratory volumes, with an increase in high acuity volumes that was exceeded by low acuity respiratory volumes. Whether or not this 5 or 6% swing in acuity and admissions within the respiratory patient population is clinically significant is to be debated. But we did see that population did act somewhat differently than its 2019 cohort. And overall, patient arrivals did reflect typical patterns that we've seen in our ED between these 2 years, suggesting that perhaps arrivals during a respiratory pandemic may reflect baseline utilization. That's all I had. Thank you. These are my references.
Hello. We investigated changes in scientific characteristics of abstracts accepted to the SAM annual meeting from 1990 to 2020. We have no financial conflicts of interest to disclose. In 1989, SAM was formed via the merger of the University Association for Emergency Medicine and the Society of Teachers of Emergency Medicine. Since then, research abstracts have been selected for presentation each year at SAM's annual meeting. Reviewers have used a scoring system from about 2005 onward. There's been a revised publicly available scoring system since 2015. Our question was, have abstract characteristics changed over time? We aim to characterize temporal changes in study design and type, topic category, single center versus multi-center design, sample size, quality score, and the percentage of abstracts published as manuscripts. We compiled published SAM abstracts for review every 5 years from 1990 to 2020. In other words, 1990, 1995, etc. We randomly sampled about 100 abstracts from each year of interest. Each abstract was reviewed by 2 investigators. When there were discrepant data, a 3rd investigator reviewed these data and the group discussed until they reached consensus. We collected data on study design and type, topic category, single center versus multi-center design, sample size, quality scores as measured using the 2020 SAM scoring criteria, and publication in PubMed along with publication year. Over the 30-year period, the number of accepted abstracts per year increased from 180 in 1990 to 879 in 2020. Study design also differed when we compared the 1990 abstracts with the 2020 abstracts. Most importantly, cohort studies became much more common, and laboratory studies became much less common. Looking at the most common abstract topic categories, in 1990 we saw cardiology, pulmonary, and airway topics accounting for about 40% of all the SAM abstracts that year. This was followed by orthopedic, trauma, burn, and EMS disaster wilderness. Together they accounted for about 71% of all the abstracts. In 2020, the most common topic was health services research, health policy, and operations. Cardiology, pulmonary, and airway had dropped to 22%, and there was a new top three, which was technology and simulation. And together these three accounted for 65%, roughly the same number as we were seeing in 1990. Continuing with our comparison of 1990 versus 2020 abstracts, we see several highly significant differences on this table. Basic science has dropped over these years, going from 20% in 1990 to 2% in 2020. Population science, on the other hand, has increased from 16% to 35%. In 2020, multi-center studies were twice as common. Sample sizes 5 times larger. And perhaps most importantly, the overall quality score, as measured by the 2020 SAM scoring criteria, has gone from 10 to 12. That's a 20% increase in the overall quality score from 1990 to 2020. Finally, with regard to publication of these SAM abstracts, across the study years from 1990 to 2015, omitting that last year because we don't know what will happen with those abstracts, but in those 25 years, between 37 to 49% of abstracts were later published as manuscripts. Unlike all of our other outcomes, there was no significant change over time. Among the abstracts resulting in publication, 21 to 25% were published within 1 year of the SAM abstract, 8 to 17% between 1 and 2 years, and 2 to 11% between 2 and 3 years. In conclusion, over the past 30 years, there have been major changes in SAM meeting abstracts. Changes in study design with less lab studies and more cohort studies. Study types with less basic science and more population science. Topics with more health services research, health policy, and operations research presented. There are more multi-center studies. There are larger sample sizes, higher quality scores. However, conversion of abstracts to published manuscripts remains a challenge, with less than 50% of the SAM abstracts going on to a published manuscript as shown on PubMed. Thank you for listening. If you have any questions or comments, you can reach me most easily at the email shown. Thanks again.
Good morning. My name is Tassif Billah. I'm an emergency resident in the Icahn School of Medicine in Mount Sinai. And this presentation is regarding our abstract pieces, performing interviews with clinicians regarding emergency shared decision-making. So just a bit of background prior to the abstract. Shared decision-making is ubiquitous and has been shown to be positively viewed amongst emergency providers in previous literature. Shared decision-making also has led to some decision aids that provide a structured conversation for specific complaints. These aids have been shown to increase patient satisfaction, engagement, as well as resource utilization and reducing it at the hospital and institutional level. However, there still has been slow uptake of these decision aids. So our objective for this abstract and study was to determine barriers and facilitators to the implementation of decision aids in the emergency department. To do so, we interviewed 20 emergency providers in semi-structured interviews regarding their perspectives on evidence-based DAs developed for chest pain and syncope. You can see here one of the decision aids we utilized, the chest pain choice decision aid, and the form that patients who have a negative chest pain workup, particularly EKG and troponin, and how it can explain to the patient options they have utilizing simple pictogram as well as layman language regarding the signs of potential MI or ACS. We also utilize this decision aid, the syncope decision aid, also known as SINDA, which also shows in the similar vein, perhaps reasons why a patient may have syncopized, future risk, personal risk estimates for this patient, in this circumstance also a low risk patient, and potential options moving forward, including observation stay versus outpatient follow-up. To kind of qualitatively analyze these providers' interviews, we utilized two framework implementation tools, the Consolidated Framework for Implementation, or CFIR, which guides implementation more so at an organization level, as well as the Theoretical Domains Framework, which espouses further on the CFIR by expanding on the individual characteristics, in this case, of emergency providers in the CFIR. So in combination, we used these two frameworks to create code books to code the 20 interviews the emergency providers undertook. From this, we gleaned some barriers and facilitators. Here you can see kind of some standard barriers we all face in the emergency department. Of note was the skepticism of the evidence base of the DAs, although there has been previous evidence about showing that the evidence base of the DAs, aforementionedly, they can help in certain circumstances. And importantly, medical legal risk, where providers were concerned what kind of liability they would face if they were to engage with these decision aids. Some facilitators we identified importantly were the institutional support of the DAs, where providers were almost near certain that they would not be able to use these DAs if there wasn't departmental and hospital institutional take-up. And another point of contention was strategic integration of DAs in the clinical workflow, which while was a facilitator in many cases regarding to the electronic health record, we'll further discuss kind of how this may have been both a facilitator and a barrier for patients. Some limitations of our study, all the emergency physicians interviewed were from one United States city, and we're all working in the same health system, providing perhaps a lack of generalizability of our study. Additionally, shared decision-making can lead to a social desirability bias. As previously mentioned, shared decision-making is widely considered a part of patient-centered medicine, and therefore could have had a desirability bias where physicians are almost obliged to report shared decision-making as something positive, given its nature as kind of the next generation or future of medicine. So ultimately from this, we can conclude that we have some decent possible implementation studies and strategies that we can use moving forward, especially the kind of ones that were previously discussed, that were discussed with a lot of the interviews with patients. So these include institutional buy-in, again, likely some requirement of the emergency departments and the institutions to make this standard of care, as well as provide medical legal reassurance, something that would be required at the level of perhaps the legal counsel, as well as the hospital institution itself. Another important thing to recognize is the effective integration into workflow, whether that's analog or electronic, and how that would fit into new electronic health records. I'd like to thank my co-authors, Mark Probst and Elizabeth Schoenfeld, as well as Lorna Gordon, for their help on this study. Thank you so much. I appreciate your time.
Hello, I'm Robbie Lindsay. I'm the Fellowship Director of Emergency Ultrasound at the University of Massachusetts. And today I'm going to be talking to you about using the Internet of Things to improve research. Funding for this project was provided through an internal grant from our department. So what is the Internet of Things? This is a concept developed over the last 20 years of physical objects, simple objects that are embedded with sensors and software to connect and exchange data with each other and users. And this has been made possible through three things: the development and ubiquity of wireless internet, the creation of production techniques such as 3D printing that allow rapid and easy prototyping and development, and the creation of tiny microprocessors for low cost. So I got interested in this when we were starting a new research project on out-of-patient cardiac arrest patients. So for this project, we actually required a fairly advanced ultrasound to be done on out-of-hospital cardiac arrest patients as they arrived to the hospital. So this needed to be done by one of our ultrasound division members. And this was very difficult because while the patient might be up in our trauma bay and there was minimal pre-notification, we might be down in our offices working on presentations or lectures or whatever else. So we needed a way to be quickly and easily notified when these patients were arriving that would be easy for the nurses and not slow them down. So I wound up creating a simple device with a single button. And the concept is that a nurse, the flow nurse, can just push it and we will all be notified. I had never done anything like this. I had never done 3D printing. I had some minimal kind of experience with coding and electronics, but I found it was much more accessible than you might expect. To actually create 3D objects to print, there are many different software solutions. I use this software called Tinkercad, which is a web-based program. You don't even need to download it. It's free, and it took less than an hour to sort of figure out how to use it. This is the actual device that we initially made. You can see there's a hole where we put the button. There are 3 holes for LED lights, and it's a hollowed out encasing that the microprocessor fits inside. So to print this, it's easy to find 3D printers nowadays. I found my local public library had one available. The university actually had one for researchers to use. And if you can't find anything locally, there are companies that you can upload your 3D files to on the internet, and they will print it and send it back to you. And the other half of this is made possible through sort of a renaissance of accessible programmable microprocessors. There are dozens of companies making low-cost microprocessors and miniature computers for anyone to use. And there are robust communities on the internet with thousands of projects that have already been done that are shared with open source licenses with schematics and code sort of uploaded. So I was able to find a similar project that someone else had already done and sort of modify it to my needs. Here you can see while I was sort of learning and tinkering with my Arduino board, and to program it, you just plug it using a USB cable straight into a standard desktop or laptop, and you can get the software to kind of code it and program it from their websites. And again, there are tutorials and there are thousands of projects already on the internet. So our device uses kind of communication through a connection to the hospital wireless internet. And it works like this. When the flow nurse receives a radio call from EMS about a patient in cardiac arrest, they were instructed to just push the button. We put the device right next to their computer at the flow desk, and all they have to do is push it. They don't need to do anything else. When they do that, within about 15 seconds, the entire ultrasound division gets notified through a shared messenger application group that the code button was pressed. We can then kind of communicate in the app ourselves, if we're able to run up and enroll the patient, if we're not available. This is a real screenshot from our group message board. So does it work? We deployed the device in November of 2020. We trained them to, again, just push the button anytime they hear a report about a cardiac arrest. And I did a chart review to determine how frequently it was being used the following month in December. So in December 2020, there were 19 patients who arrived to the hospital in cardiac arrest. The flow nurse correctly activated the device for about 70% of those patients. And we were able to enroll about half of them into our study. And you might think that doesn't sound great, but for such a complicated study where we needed an advanced ultrasound done within minutes of arrival, I would give that a gold star or maybe a silver star. But either way, we were very happy with it. So thank you very much. And if you have any questions, or if you would like to learn more about this, or if you have any ideas that you want to develop, please reach out to me. Thank you very much.
Today, I'll be presenting a review of COVID-19 related publications and lag times during the first 6 months of 2020. All authors are affiliated with the University of California, San Francisco's Emergency Medicine Department and help with study design, data abstraction, and writing and editing of the manuscript. I'd like to specifically acknowledge the senior author, Dr. Rodriguez, who played an instrumental role guiding us from start to finish on this project. Finally, all authors have no funding or disclosures to report. Near the end of 2019, reports of a novel virus began surfacing, and not long after that, by January 4th, 2020, we had our first World Health Organization confirmed case of COVID-19. About 6 months later, by June 30th, we had more than 10 million cases of COVID-19 confirmed globally and more than 500,000 deaths confirmed. COVID-19 ushered in a rapid need for critical information and original research regarding approaches to prevention and treatment. Given this need for information, we sought to evaluate lag times of COVID-19 related research production and characterize publications in top-ranked peer-reviewed medical journals. We reviewed the 125 top-ranked journals as ranked by Schmago under the category of medicine. We included every journal on this list of 125 regardless of focus, be it clinical or lab. We performed data collection using a systematic approach where we went to each respective journal's website and used the embedded search function to search for the keywords COVID-19, SARS-CoV-2, or coronavirus. We abstracted all articles returned in these searches that were published online in the date range between January 1st, 2020 and June 30th, 2020. Separately, some journals had a COVID-19 collection of articles. And if that was the case, we abstracted all articles published in these COVID-19 collections in lieu of using a keyword search, again, during the same date range, January 1st to June 30th, 2020. We abstracted article title, date of online publication, and when it was available, the date of submission. We then categorized all articles as one of the following: original research, which was the presentation of original data; case report, a single patient presentation; review, summary of literature on a given topic; or commentary, which would be a perspective or guidelines, correspondence, editorials, anything not presenting original data. Finally, we abstracted all preprint articles from the Dimensions database, which is a database that uses artificial intelligence to compile information pertaining to the complete research cycle. We then compared preprint publication dates with journal publication dates and submission dates and publication dates within the journals we evaluated. Focusing on original research, we sought to determine lag times in days between global cumulative World Health Organization confirmed cases of COVID-19 and peer-reviewed journal publications, between preprint publication of articles and publication of those same articles in peer-reviewed journals, and finally, between submissions to peer-reviewed journals and then subsequent publication within that journal. Our secondary outcome was the characterization of COVID-19 related publications. In the figure, we presented data of COVID-19 cases, deaths, and publications over time on a logarithmic scale to account for viral spreading. We found that the first original research articles were published just 20 days after the first World Health Organization confirmed case of COVID-19, and the slopes of the publication curves mirror the slope of the pandemic curve, albeit roughly 1 month behind. We found the median lag time between article preprint publication and peer-reviewed journal publication to be 32 days. And of the 709 original research articles that we abstracted, 108 of them had been published as preprints. Next, we found the median lag time between article submission and publication in a peer-reviewed journal to be 30 days. And of the 709 original research articles, 282 of them had original submission dates publicly available. Finally, commentaries made up the overwhelming majority of COVID-19 publications, coming in at over 1,500, while original research made up just over a quarter of publications. Reviews and case reports made up about 7 and 3% respectively. Although we did not have a true baseline, we were able to find a few reference points. And prior to the pandemic, Herbert et al. Evaluated over 8,000 preprint articles published on bioRxiv in the year 2019. And they found a publication lag time from preprint to peer-reviewed journal of 160 days compared to our 32-day lag time. Separately, Sean et al. Found a median lag time from submission to publication within the British Medical Journal in 2019 of 194 days. And the British Medical Journal is included in the 125 of the journals we evaluated. Finally, we found a rapid and robust response to meet the need for original research regarding approaches to prevention and treatment of COVID-19.
Hello, my name is Emmanuel Quaidu, and I'll be presenting a review of COVID-19 related emergency medicine journal publications and lag times. All authors are affiliated with the University of California, San Francisco's Emergency Medicine Department and helped with study design, data extraction, and writing and editing the manuscript. I would like to give a special acknowledgement to our senior author, Dr. Rodriguez, who was instrumental in completing the project. All authors have no disclosures of fundings to report. On January 4th, the first case of COVID-19 was confirmed by the World Health Organization. Over the next 6 months, there would be over 10 million cases of the pandemic confirmed worldwide, with over 500,000 deaths, numbers which are horrifically higher today. The widespread impact of the virus created an urgent need for research to better understand the phenomenon. In addition, the worldwide attention of the virus has led to additional nuances in conducting and distributing research. Because of this expedited need for research, we evaluated the lag times of COVID-19 related research production and characterized publications in top-ranked peer-reviewed emergency medicine journals to better understand the changes in the research process related to COVID. We reviewed the 20 top-ranked peer-reviewed emergency medicine journals, ranked by impact factor according to Rodriguez et al. In the West Jam in 2020, between January 1st and June 30th. We went through journals in a systematic approach where we went to each journal's website and used the embedded search function to search for the keywords COVID-19, SARS-CoV-2, or coronavirus, similar to another review our group performed looking at internal medicine journals. We extracted all articles returned in these searches that were published online from January 1st through June 30th. Separately, some journals had a specific COVID-19 collection of articles. For these journals, we extracted all articles in these COVID-19 collections in lieu of using a keyword search. We extracted the article title, date of online publication, and when available, the date of submission. We categorized all articles as one of the following: original research, case reports, reviews, or commentary, a category which included perspectives, guidelines, correspondence, editorials, or anything else not presenting original data. Finally, we searched for preprint articles for all identified publications in our study period in the Dimensions database, a database which uses artificial intelligence to compile information pertaining to the complete research process. We then compared preprint publication dates to journal publication dates and submission dates to publication dates within journals we evaluated. Focusing on original research for our primary outcome, we sought to determine the lag time in days between the first global World Health Organization confirmed case of COVID-19 and the first publication in the peer-reviewed EM journal. In addition, we collected the median lag time between preprint publication and publication of those articles in a peer-reviewed emergency medicine journal, and median lag time between submission to peer-reviewed EM journals and publications within these journals. Our secondary outcome was to characterize COVID-19 related publications to determine which type of research publications were more common. In the figure shown, we presented data of COVID-19 cases, deaths, and articles over a 6-month period on a logarithmic scale. We found that the first original research articles in an emergency medicine journal were published on March 2nd, 58 days after the first World Health Organization confirmed case of COVID-19. The number of publications followed a similar trend to the number of cases, albeit with a less steep slope and starting later. As for our other primary outcomes, the median lag time between article submission and publication in a peer-reviewed journal was 26 days. Of the 83 original research articles found, a little over 10% had been published as preprints. The median lag time between original research article submission and publication in a peer-reviewed journal was 23 days. 67 of the original research articles had original submission dates publicly available. For our secondary outcome, Out of 351 journal publications, commentaries were the most common type at about 54%, or 191 journals. A little under a quarter of our publications involved original research, with the remaining made up of reviews and case reports. To get a sense of how these lag times compare to pre-pandemic lag times, we identified a couple of research studies as references. A study by Herbert et al. In 2019 evaluated over 8,000 preprint articles published on bioRxiv during that year and found a lag time of 160 days. Another study, Shan et al. In 2020 noted that the median time from submission to publication of an article in the British Medical Journal in 2019 was 194 days, both much longer periods of time than we noted in our study. Some limitations included the completeness of the preprint and dimension databases, the use of only free access information, and the significance of the rankings used for journal selection. Nevertheless, our data suggests an impressive reduction in lag times to publications in emergency medicine journals to meet the needs for original research in COVID-19. Thank you very much for your time.